Hiya, Smarties. I hope you're all doing okay. This is Royan reporting to you live from not sunny Sacramento, California. I've been doing my medical externship here at the UC Davis Med Center's Center for Voice and Swallowing. So I've learned a lot about how to perform laryngoscopy and videostroboscopy using a flexible endoscope, and I thought I'd provide you all with an in-depth look in case you need to use this in the future. What I'll give you more of is voice rather than swallowing, although you can use a flexible endoscope to perform a FEES. But essentially, you're looking at the nasopharynx, oropharynx, the larynx, from the base of tongue down to the vocal folds, or even beyond a little bit. You're not putting the scope past the vocal folds, but you're looking at the proximal trachea. You can also look at the UES. If you're using strobe, you're visualizing the vocal fold motion. You can also, as I said, use this to assess swallowing function. So essentially, you're looking at the 3Ds: dysphonia, dyspnea, dysphagia, as well as chronic cough or throat clearing. So you need to spray the patient's nostrils with two different topical sprays. That's what we use. First, we provide the patient with two tissues because sometimes things dribble out the front. You have to inform the patient of each step of what you're doing, as well as the purpose of each spray. We have this kind of disposable attachment for an atomizer. We pop that onto each bottle, and then you use that atomizer to kind of lift the nostril a bit so that you can spray up and diagonally back into the cavity and onto the turbinates. You're not so much straight back, like along the septum line. You want to be a slightly diagonal. Afrin is first. That's a decongestant, 2 sprays per nostril at least. Lidocaine is next. That's a numbing agent, and same thing, 2 sprays per nostril. Instruct the patient to sniff and swallow after that. If you're avoiding an aerosol generating procedure or an AGP, you can apply some lidocaine to a cotton swab or pledgelet and apply that to the nair. Plugging it all in, it's important that you carry all of the elements all at once so that you don't drop any of them. You first plug the largest element, which is the camera, into the camera feed on the tower. You close the gate to lock it in place. Next, the smallest element in your hand is plugged into the light source, either strobe or halogen. The final element, obviously, is the scope controller and the scope cable. So if the patient complaint involves the voice, you definitely want to use strobe so you can see that vocal fold motion. Otherwise, you'll use halogen because a strobe bulb tends to burn out around 100 hours of use. If you're performing a scope without strobe, you'll need only one microphone so that you can record the audio that syncs up to the video for later playback. With strobe, you'll also need a special laryngeal microphone, which you can see in the picture as well. It kind of looks like a stethoscope. You hold it against the patient's thyroid shield, not on the actual thyroid notch, like in the front. You hold it flat against the shield, which makes the notch. So this captures the patient's fundamental frequency when they're voicing, and then synchronizes it to the strobe for that slow-mo effect of the vocal folds. The other microphone is called a lavalier microphone, and it can be clipped to the patient's clothes right here, so you can hear their voice loud and clear in the room. I've been told there's a few different ways of holding the strobe, but this video demonstrates our level. Your elbow is bent, your hand's at your shoulder level. The tip angulation toggle or the thumb toggle or the trigger is closest to your thumb facing you. The buttons for narrowband imaging or light filters are up top. Try to hold the scope using only your fingers and your knuckles right there, rather than resting it on your palm or even your thumb. That will provide less tension on your thumb, and that's what you need to use to quickly and easily toggle up and down. So we tell the patient to use a sniffing posture. This is also used in rigid endoscopy through the mouth, but you have the patient scoot all the way back in the chair, have them lean forward at the waist, and then support themselves with their hands on their laps, tilt their chin upwards. That provides a comfortable experience for them, but also a very unobstructed image when looking down. If the chair that you're using has a hydraulic lift, you're going to lift the chair so the patient's nose is kind of generally at your shoulder level when you're scoping. If you're using a halogen light source, You need to calibrate the white balance. There's some different tools that you need to use that. Sometimes there's a little plastic tube that's white. You pop the scope cable in there, press the white balance button on the main console, and that'll do it for you. You need to apply some lidocaine jelly, or it's recommended. Not all patients want it, but you can. You can squirt some lidocaine jelly onto a 4x4 gauze and then apply that to the last 4 to 6 inches of the scope cable. Lower the lights in the room, turn on the scope light. What I like to do is test the thumb toggle while looking at the displays. So I point the camera right at my gloved hand, and I use the thumb toggle up, down, so that I can see if there's any delay on the video cameras as well. And remember that with the thumb toggle, up is down is up with the angulation. It's a little odd. You gotta press record or else you'll have to do the scope all over again, and nobody wants that. While you're holding the scope implement, the control with your dominant hand, use the other hand to feed the scope cable in, and then you can anchor using one more finger of that same hand against the patient's nair or their cheekbone. Use the dominant hand holding the controller to push the tube forward. You want to hug the cavity floor as low as possible, as well as the turbinate closest to the septum. So the septum's on the midline, but it's a little sensitive. So you want to hug the turbinate that's right next to it and pass right on through that direction. So you can tell the patient, all right, that was the most uncomfortable part you just did there, or you're going to feel some pressure right here. Or what I like to say is nice, easy breathing through the nose. Mindfulness breathing is incredibly helpful if you have a patient who is frequently gagging or is very anxious. And if in doubt, if things fog up on your view, just aim for the dark. Pop it back in there. So once you're in the VP port, you want to test sufficiency of the port closure. What I like to do is Coca-Cola. It's rapid closure, or you can do is extended closure. Thumb toggle down when you pass the VP port. Whenever the camera view is foggy or blurry or obscured, you want the patient to swallow so that any of the gunk on the camera can clear away. Have them swallow as many times as you can get a clear image. Keep the vocal folds in the center of the frame as much as possible. And you do that by rotating your wrists left or right, or by using the thumb toggle up or down as much as possible. Use your pixels, get in really, really close. I think especially if you have a flexible endoscope that is not distal chip, that might be a poorer video quality than distal chip is. So get in close if you can. That's what the flexible scope does well in reference to, say, a rigid endoscope. Don't ever touch the vocal folds with the scope, though. You might trigger a laryngospasm and the patient might lose trust with you. So these are my vocal folds in action right there, which is pretty fun. The first task we'd like to do, stick your tongue all the way out, and then thumb toggle down and rotate a bit to find the valleculae in the base of tongue and see if that's clear. Have them relax the tongue back in. Take a nice breath in and hold E as long as you can. Once phonation starts there, advance closely so you can see as much of the true vocal folds as possible. And then when they get to the end of phonation or the end of their breath, retreat. Sniff through your nose quickly like this. So you're looking at gross movement of the arytenoids or vocal fold mobility, as well as a bit of subglottic clearance. Later, if you want, you can try a slow sniff in, like you're smelling flowers. That can reduce a little bit of hyperfunction. So after that quick sniff, have them alternate between a sniff and a he, like this. He. You're looking for rapid gross movement of the vocal folds, as you can see in the video right there. Is either vocal fold sluggish or hypomobile? Glide up on the he, sound like this, and then you demonstrate he all the way up high. Does the pitch change stop abruptly or early? And now glide down like this. He. What's the vocal quality like on their lowest notes? Is it clear all the way through? Are there phonation breaks? Puff out your cheeks. You're looking at the piriform sinuses. So when you do that, you're kind of expanding the oropharynx right there, and you can see a better view of those piriform sinuses, which in the video is in the top left and top right. Here's some optional tasks that you can do. Make a high-pitched sound like a spider monkey, like this. Yee! This can demonstrate pharyngeal constriction for swallowing function. Nice breath in and hold out ooh as long as you can. Sometimes that different tongue posture for the vowel can release base of tongue tension and reduce supraglottic hyperfunction. Make a surprise sound like this on an ah shape. This can get a better view of Reinke's edema. So if your patient is a smoker or has been a smoker, you definitely want to do the Reinke's test in whatever way that you can. With this one, you've got those vocal folds opening, but it also kind of spreads the false folds on top of them, and you can see something a little bit different. If the patient is a professional singer or their primary complaint is singing, have them sing a portion of a song they know or just happy birthday. Once you've completed all the tasks that you need, get the hell out of there. So tell the patient that the scope is coming out and then get the scope out smoothly, but swiftly. Removing it slowly will be more painful. Stop the recording, stop the scope light source, place the scope on a stable surface so that it doesn't slip off. Offer more tissues to the patient if you need. Turn the room lights back up, and then reset the height of the chair. That one's very important because if you've lifted the patient pretty high and you haven't reset it, if they try to get off that chair, that could be a liability. They could injure themselves. So you definitely want to reset the chair to its lowest position before you leave the room. And that is it. Let me know if you have any questions or comments, or if anything is unclear. I hope this was helpful for someone who might be venturing into a hospital where they might have to do this for the first time. So yeah, have a great day. Bye.